Welcome to the Repore Review Podcast, your space for education, conversation, growth, and change. Sandy and Chip, with every brief episode, will take a moment to slow down, reflect, and explore counseling, its challenges, and victories that shape daily lives. Whether you're a therapist, a client, or simply someone on a journey of personal development, you're in the right place. Let's dive in, learn together, and keep moving forward. This is the Repore Review Podcast.
Today, we're taking on a really critical and complex topic, post-traumatic stress disorder, or PTSD.
And this is such a crucial deep dive to do right now. The whole landscape of care is just, it's fundamentally changing.
It really is.
Our sources are covering everything from, the precise neurobiology of how trauma gets lodged in the brain, all the way to the gold standard therapies and some, frankly, radical new drug therapies.
So our mission today is to synthesize all of this for you. We want to cut through the noise and give you a comprehensive but not overwhelming look at the full spectrum of PTSD care.
And we're going to start somewhere you might not expect. Not in a clinic, but in, the world of high technology.
Yeah, we're opening with what I found to be the most surprising part of the research, using artificial intelligence to help with the huge shortage of clinical mental health staff.
It's fascinating stuff.
I mean, we're talking about using large language models, LLMs. You've probably heard of GPT-4 and Llama 2 to automate or at least assist in diagnosing PTSD.
And this isn't just a theory. There's a major project from Emory University and Georgia State University.
Right.
They built this really sophisticated framework, and it's designed to analyze these long, clinician-led diagnostic interviews. The scale is pretty amazing. They fed the models over 700 hours of conversations.
700 hours?
Yeah, from 411 different clinical assessments.
So the question for you listening is how? How can a language model actually diagnose trauma? What is it even listening for?
Well, it's analyzing linguistic patterns, the very structure of how someone tells their story. It looks for these specific markers, like shifts in emotional valence.
The positive or negative charge of a memory.
Exactly. Or repeated stories, signs of avoidance in the language, even the intensity of the words used when talking about things like safety or trust.
So the AI isn't just hearing what was said.
Oh.
It's hearing how it was said. And the goal here, as the sources really stress, isn't to replace clinicians.
Not at all. It's about validation, providing a kind of objective second opinion that can help speed up assessments and make them more accessible.
It's an incredible start. So, okay, let's unpack the problem these diagnostics are trying to identify. Let's move from the tech to the biology. What is PTSD actually doing inside the brain?
Well, it's important to know this isn't just psychological. It's a physiological hijack of the system.
Right, like with adrenaline. Its normal job is to power that fight or flight response in an emergency.
But in PTSD, that switch is it's stuck in the on position. People keep producing these massive amounts of stress hormones even when they're completely safe.
And that chronic adrenaline overload, that creates real physical symptoms. It's what fuels that feeling of hyperarousal, being constantly on edge.
That exaggerated startle response.
Yeah.
Right? It's exhausting. And it's also linked to the emotional numbing that so many survivors feel because the body is it's perpetually in defense mode and drained.
And the brain itself can structurally change. We know from the research that in people with PTSD, the hippocampus,
The part of the brain for memory and emotion.
that part can actually appear physically smaller.
And this is where we get to the root of those debilitating symptoms, like flashbacks and nightmares.
Okay.
Normally, the hippocampus takes a traumatic event and processes it. It adds context and timestamps. It files the memory away as explicit.
Something that happened in the past.
Exactly. But if the hippocampus is malfunctioning, that memory stays implicit. It's stored in these fragmented bits, sensations, sounds, emotions, without the context that tells you this is over.
So the brain keeps reliving it as if it's happening right now. The anxiety never goes down because the brain hasn't filed away that one critical piece of information.
Yeah.
You survived, and you are safe now.
Precisely. And so treatment is really all about forcing that integration, that proper filing.
But before we get to the treatments, we have to make an important distinction. The difference between trauma from a single event and something called complex PTSD, CPTSD.
Yes. CPTSD comes from trauma that's prolonged and repeated. It often happens in situations where the victim is controlled by someone else and can't escape.
Things like chronic child abuse, severe neglect, or long-term domestic violence.
Right. And the symptoms are just so much more wide-ranging. You get the core PTSD symptoms, the re-experiencing, the avoidance, the hyper-arousal. But you also see these profound difficulties with emotional regulation, with relationships, a really negative self-perception.
It impacts every area of life.
Every area. And what's really important for you to know is that while CPTSD is a recognized clinical reality around the world, the main diagnostic manual in the U.S., the DSM-5-TR.
It doesn't actually recognize it as a separate diagnosis.
No, it lumps the symptoms in with standard PTSD criteria, which many experts argue just doesn't capture the full picture of that kind of long-term interpersonal trauma.
Which makes getting the right kind of tailored care that much harder.
It does, and that sets us up perfectly to talk about that care. If the brain is stuck, how do we get it unstuck? So let's turn to the gold standards of psychotherapy.
Okay, so if you look at what all the major organizations recommend, the VA, the American Psychological Association, and so on, 3 therapies consistently come out on top.
The first one is prolonged exposure, or PE.
And this one is built on a pretty straightforward idea, emotional processing theory. You have to confront the memories to change the fear.
It's very behavioral. It has 3 main parts. First, psychoeducation, just understanding what's happening. Second, something called in vivo confrontation.
Which means facing things in real life.
Exactly.
Yeah.
Intentionally going to safe places or situations that you've been avoiding because they're linked to the trauma. And third, repeated imaginal exposure.
This is the really intense part, right, where you revisit and describe the trauma memory over and over.
Yes, often in the present tense, and you might even record it to listen to it. The idea is to desensitize the fear response. And the numbers are impressive. 68% of people who finish PE no longer meet the criteria for PTSD.
That is a huge success rate.
It is, but, and this is a really critical but from the sources, the intensity of it means the dropout rates are famously high.
I saw that. Sometimes over 50%.
Right, which leaves a lot of people still struggling. It forces you to ask, if the treatment is too intense for half the people who try it, is it really the best first choice for everyone?
And that's probably why we have alternatives like the second gold standard, cognitive processing therapy, or CPT.
CPT shifts the focus from the raw emotion of the event to the thought process after the event. The theory is that PTSD is maintained by what it calls stuck points.
These are the inaccurate, negative beliefs that the trauma creates about yourself or the world.
Exactly. Like assimilation, where you change the facts of the trauma to fit an old belief. For instance, I deserve to be assaulted because I'm a bad person.
Or the opposite, over-accommodation, where you radically change your beliefs about everything. Because this happened, I can never trust anyone again. The world is totally dangerous.
And CPT works to challenge and restructure those specific thoughts. It's another powerhouse treatment, highly recommended, and often better for people who can't tolerate the intensity of PE.
And then there's the third one, eye movement desensitization and reprocessing, EMDR.
Right, and EMDR has a different theory. It's called the Adaptive Information Processing Model. It says the traumatic memory is stored in a fragmented, dysfunctional way, and that's what's blocking healing.
And the technique itself is really unique. It uses sensory input while you process the memory.
Precisely. While you focus on the traumatic memory, the therapist guides you through some form of bilateral stimulation. Maybe your eyes follow a light back and forth, or you get taps on your hands.
And the idea is that this helps the brain link all those fragmented pieces, the images, the feelings, the sensations, into a cohesive story that it can finally file away.
And one of the huge advantages people point to with EMDR is that it tends to work faster, and it often has less sort of homework between sessions compared to CPT and PE.
So there isn't one single right answer. It's about finding the right fit for the individual.
Absolutely. So moving beyond talk therapy, let's look at pharmacology. And we have to start with the most disruptive symptom of all, sleep.
Oh, definitely. Insomnia and nightmares are so core to PTSD that just getting sleep under control can be the key that unlocks recovery.
For general insomnia, the sources are crystal clear. The best treatment is cognitive behavioral therapy for insomnia, or CBTI.
Not medication?
No, it's recommended over medication because it's more effective, it helps about 7 out of 10 people, and there's no risk of dependence.
But for those really relentless, terrifying nightmares, there is a specific medication that can help.
Prazosin. It's actually a blood pressure medication, but it's proven to be very effective for trauma-related nightmares. It's a really targeted intervention.
And the data there was interesting. It noted that women often need a lower dose than men.
Yeah, getting that dosage right is absolutely critical for managing that one specific awful symptom.
Okay, so for overall medication, the first line is still the traditional antidepressants, SSRIs and SNRIs, things like sertraline and venlafaxine.
They are definitely helpful for the depression and anxiety that often come with PTSD, but we have to be honest about their limits. Only about 20 to 30% of people get complete remission on these drugs alone.
Which is why it's usually a combined approach.
Always. And this brings us to a really important warning about a common class of anxiety meds, benzodiazepines.
They might seem like an obvious choice for a panic-related disorder, but they're generally not recommended for PTSD.
Absolutely not, for two very serious reasons. First, there's a really high overlap between PTSD and substance use disorders, so the abuse potential is a huge concern.
And second,
And this might be even more important for recovery, they impair your memory. They actually interfere with the very process of memory consolidation that therapies like PE and CPT rely on to work.
so they can block the healing process that the therapy is trying to create.
They can, which is why we avoid them.
Okay, let's pivot now to the absolute frontier. The innovative, sometimes radical, drug-assisted therapies for treatment-resistant PTSD.
This is where we get into things like ketamine and MDMA-assisted psychotherapy.
So with ketamine, the reviews show it has potential benefits, but they seem to show up after a full course of treatment over several weeks.
Right. The insight there is that the immediate effects, say within 24 hours, aren't always that significant. It seems to be about the neuroplastic changes that happen over time.
And then there's MDMA-assisted psychotherapy, which the FDA has designated a breakthrough therapy. The mechanism here is what's so incredible.
It has this amazing dual effect. It increases positive feelings like empathy, relaxation, and closeness, while at the same time, it quiets down the parts of the brain associated with fear, like the amygdala.
It creates a window.
It creates a chemical window. It allows a person to revisit and process traumatic memories in a safe therapeutic setting without being completely overwhelmed by terror.
And the data on just keeping people in treatment is astounding. It speaks directly to that dropout problem we mentioned with PE and CPT.
It really does. The dropout rates in the MDMA trials were incredibly low, around 6.8%.
Compare that to the 47% for CPT and 56% for PE that are sometimes reported.
And remember, these trials included people who had already failed every other available treatment. It suggests the experience is just far more tolerable for them.
Now, we should acknowledge a challenge with the studies: functional unblinding. It's pretty easy for participants to guess if they got the real drug.
That's a valid methodological hurdle for sure.
Right.
But the signs of efficacy are still incredibly strong.
Okay, so balancing these intensive therapies, we also need to talk about holistic skills, the tools that build resilience day to day.
This is so important. Survivors need things they can use in the moment. A great framework for this is dialectical behavior therapy, or DBT.
Which wasn't originally for PTSD, right?
No, it was for borderline personality disorder. But its focus on managing intense emotions and self-destructive behaviors is just a perfect fit for the dysregulation you see in complex trauma.
It teaches those 4 skills: mindfulness, emotional regulation, distress tolerance.
Which is about getting through intense pain without making things worse, and interpersonal effectiveness.
And just building active coping skills in general, it creates a sense of empowerment. Even something as simple as psychoeducation, just learning about your symptoms helps you realize, I'm not alone, I'm not weak.
And practical techniques, like grounding exercises for flashbacks, things you can do.
Like keeping your eyes open, moving around, reminding yourself of the current date and time.
Exactly. Or using distraction with positive things, like art or music. And we can't forget the body itself.
Trauma-informed yoga.
Yes. This specific kind of yoga uses movement and mindfulness to gently work with the body's defensive responses, that fight, flight, or freeze mode, and help survivors feel safe in their own bodies again.
And finally, we have to mention peer support. It is not a replacement for therapy.
No, but it's a vital supplement. That feeling of isolation is so damaging. Connecting with others who have been through it reduces stigma and loneliness, and it promotes so much hope.
So today, we've really journeyed across the entire clinical landscape of PTSD. We started with AI helping with diagnosis.
Move through the biology of the hippocampus and how memory gets stuck.
We covered the gold standards, PE, CPT, and EMDR, and the specific role of medications like prazosin for nightmares.
And we ended on the frontier with MDMA-assisted therapy, which requires this deep, human, empathic guidance, and all the holistic skills that help people manage their daily lives.
And this whole synthesis leaves us with I think, a really provocative question for you to think about. On the one hand, we have technology that can assess trauma from language data alone, purely objective.
And on the other, we have treatments like MDMA-AP that have incredible potential but demand this deeply subjective, compassionate human guidance to even work.
So where does the future of mental health recovery lie? Will the next great leap be powered by purely objective algorithms?
Or will it be powered by these deeply human, subjective experiences that are unlocked by breakthroughs in neuroscience?
It's probably a bit of both, and understanding that tension between high-tech and high-touch care is going to define the way forward. Thank you for joining us on this deep dive.
We really encourage you to continue exploring the incredible progress being made in this field.
Thank you for joining today's Repore Review. If this episode connected with you, inspired you, or gave you something meaningful to reflect on, I'd love for you to share it with someone who might need it too. Be sure to subscribe so you never miss an episode. Until next time, stay grounded, stay growing, and take good care of yourself. This is Antonio, signing off from the Repore Review Podcast.